Hello everyone, it's Dr. Locklear here, and I'm coming to you with Exemplar 1A, the concept of acid-base balance with metabolic acidosis. So we have Exemplar 1A, 1B, 1C, and 1D. So let's get started. We're going to talk about the pathophysiology of metabolic acidosis, what causes it, what's the process it goes through and the causes, the risk factors and prevention. We're going to look at the clinical manifestations. So as a nurse, what will you see with someone with metabolic acidosis? What are the diagnostic tests? And that's important because you need to know how to interpret that ABG as we saw in the concept of acid-base balance. What kind of care do we provide with patients that are in metabolic acidosis? And how do we apply the nursing process to each individual person during metabolic acidosis? So what's our overview? Metabolic acidosis, which is a bicarbonate deficit, is characterized by a low pH, less than 7.35, and a low bicarbonate, less than 24 milliequivalents per liter. It may be caused by excess acid in the body or loss of bicarbonate from the body, and we'll talk about the reasons for that. When metabolic acidosis develops, the respiratory system attempts to return the pH to normal by increasing the rate and depth of the respirations. Again, here we're talking about compensation. Carbon dioxide elimination increases and the PaCO2 falls to less than 35. And so, again, the body tries to compensate. So when you're a metabolic, your respiratory will try to attempt to return the pH to normal. So the patho has four basic mechanisms: accumulation of metabolic acids, excess loss of bicarbonate, an increase in chloride levels, and fluid balance. An accumulation of metabolic acids can result from excess acid production or impaired renal elimination of metabolic acids. Lactic acidosis develops due to tissue hypoxia and a shift to anaerobic metabolism by the cells. And lactic acidosis is deadly. It's very hard to turn someone around from lactic acidosis. Lactate and hydrogen ions are produced, forming lactic acid. So it comes from lactate and hydrogen ions. So when you have this development of lactic acidosis, you see a shift to that anaerobic metabolism. Both oxygen and glucose are necessary for normal cell metabolism. When intracellular glucose is inadequate because of starvation or a lack of insulin to move it into the cells, the body breaks down fatty tissue to meet its metabolic needs. In this process, fatty acids are released and converted to ketones, ketoacidosis. And that's what I was telling you about in diabetic ketoacidosis. The body it'll break down fats, it'll break down muscle, it'll start to break down whatever it can to get that energy. Aspirin, acetylsalicylic acid, breaks down into silicic acid in the body. Substances such as aspirin, methanol or wood alcohol, and ethylene contained in antifreeze and solvents cause a toxic increase in body acids by either breaking down into acid products, silicic acid, or stimulating metabolic acid production. So again, we're talking about the patho and things that can cause metabolic acidosis. Hypovolemia from dehydration will cause metabolic acidosis as well, contributing to other conditions such as bicarbonate that is lost in stool, ketones produced with starvation such as in eating disorders, ketoacidosis from decreased tissue perfusion and decreased renal perfusion. Renal, failure impairs the body's ability to excrete excess hydrogen ions and form bicarbonate. Excess metabolic acids can increase the hydrogen ion concentration of body fluids. The buffering of excess acid by bicarbonate leads to what is known as a high anion gap acidosis, and you'll see the anion gap on your lab report. The pancreas secretes bicarbonate-rich fluid into the small intestines. Intestinal suction, severe diarrhea, ileostomy drainage, or fistulas can lead to excess loss of bicarbonate. Hyperchloric acidosis can develop when excess of a chloride solution, such as sodium chloride, is infused, causing a rise in chloride concentrations. It is also related to renal disease or administration of carbonic and hydrate inhibitor diuretics. The anion gap remains normal in metabolic acidosis because of bicarbonate loss or excess chloride. Acidosis depresses cell membrane excitability, affecting neuromuscular function. It also increases the amount of free calcium in extracellular fluid by interfering with protein binding. Severe acidosis, a pH of less than 7 or 7 or less, depresses myocardial contractility, leading to decreased cardiac output. If kidney function is normal, acid excretion and ammonia production increase to eliminate excess hydrogen ions. Acid-base imbalances also affect electrolyte imbalances, and we've already talked about some of the issues that can occur with electrolyte imbalances. In acidosis, potassium is retained as the kidney excretes excess hydrogen ions, so we know that too much potassium can cause cardiac dysrhythmias. Excess hydrogen ion also enter the cells, displacing potassium from the intracellular space to maintain the balance of cations and anions within the cells. The effect of both processes is to increase serum potassium levels. Also in acidosis, calcium is released from its bonds with plasma proteins, increasing the amount of ionized free calcium in the blood. Magnesium levels may fall in acidosis. So we know magnesium and potassium all affect the heart muscle and all of our muscles. So it can not only cause heart problems, but respiratory problems as well, because we need our muscles to breathe. So what is our etiology? Metabolic acidosis is rarely a primary disorder. It's usually from other diseases. Acute lactic acidosis usually results from tissue hypoxia due to shock or cardiac arrest. Patients with type 1 diabetes mellitus are at risk for developing DKA. Acute or chronic renal failure impairs the excretion of metabolic acids. Diarrhea, intestinal suction, abdominal fistulas, these also increase the risk for excess bicarbonate loss. Ingestion of an acidic substance or a substance that can be metabolized to an acid. So anything that's considered like the aspirin they were talking about earlier. Some of the risk factors include DKA, renal failure, severe sepsis, liver failure, and salicylate intoxication. Metabolic acidosis from severe diarrhea can occur at any age. Young women with eating disorders who abuse laxatives or engage in severe diet restrictions to the point of cachexia or wasting syndrome. This is where you see acute weight loss and acute muscle loss, are at increased risk of metabolic acidosis due to the resulting decrease in bicarbonate. Other common causes are listed under your clinical manifestations and therapies on page 14. So you see under metabolic acidosis, this is conditions that can increase non-volatile acids in the blood, renal impairment, diabetes, starvation, conditions that decrease bicarbonate or prolonged diarrhea, excessive use of laxatives, excessive infusion of chloride containing IVs such as sodium chloride, excessive ingestion of acids such as salicylates like in aspirin, and cardiac arrest. The clinical manifestations that may be apparent are diminished appetite, nausea and vomiting, abdominal pain, weakness, fatigue, headache, general malaise, decreasing level of consciousness, dysrhythmia, bradycardia, warm flushed skin, skeletal problems, hyperventilation, those rapid deep respirations that are called Kussmaul respirations, and dyspnea or shortness of breath. Monitor the ABG values, monitor the I and O and the level of consciousness. Position patient to facilitate chest expansion, put the head of the bed up. Provide oral care for a dry mouth. Administer IV sodium bicarbonate carefully as ordered and monitor the patient because remember, if we give too much bicarbonate, it can cause them to go into metabolic alkalosis. Treat underlying problem as ordered. And of course, the physician would be doing that, and we would be following the physician orders. Clinical manifestations. Metabolic acidosis affects the function of many body systems. In general, you see weakness, fatigue, headache, and general malaise. The effects on the GI tract cause diminished appetite, nausea, vomiting, and abdominal pain. The level of consciousness may decline into stupor and coma. Cardiac dysrhythmias may develop and cardiac arrest. So this patient needs to be on a monitor. They need to be probably in ICU and being monitored in critical care. The skin is often warm and flushed. Skeletal problems may develop in chronic acidosis, such as you'll see as calcium and phosphate are released from the bone. So let me say that again. I got stumbled up. Skeletal problems may develop in chronic acidosis as calcium and phosphate are released from the bones. So during metabolic acidosis, the bones are doing some stuff too. They're spilling calcium and phosphate. Manifestations of compensatory mechanisms are seen. So now the respiratory is kicking in. We're going to breathe harder and deeper and faster because we're trying to blow off the CO2. The deep and rapid respirations that may occur are Kussmauls. The patient may complain of shortness of breath or dyspnea. They need to be on oxygen. So collaboration, the focus is on treating the primary disorder, reducing the effects of acidosis on cardiac function, and ensuring adequate oxygenation. Look at the patient's history for any predisposing or contributing factors. Look at the serum electrolytes, especially potassium. Replace fluids as needed and modify the diet as necessary. The diagnostic tests include ABGs, serum electrolytes, and tests as indicated by the underlying primary disorder. And then our pharmacologic therapy. To reduce the effects of acidosis on cardiac function, an alkalinizing solution, such as bicarbonate, may be given if the pH is less than 7.1. Sodium bicarb is the most commonly used alkalizing solution. Others include lactate, citrate, and acetate solutions, which are metabolized to bicarbonate. Giving alkalinizing solutions IV for severe acute metabolic acidosis. Use the oral route for chronic metabolic acidosis. Carefully monitor patients' treatment with bicarb. Rapid correction of the acidosis may lead to metabolic alkalosis and hypokalemia. Hypernatremia and hyperosmolality may develop as well, leading to water retention and fluid overload. And we remember in the other chapter we talked about DKA and hyperosmolar situation where it's not breaking down the ketones as DKA does, and it's a very life-threatening situation. As metabolic acidosis is corrected, potassium shifts back into the intracellular space. This shift can lead to hypokalemia and cardiac dysrhythmias. Carefully monitor potassium levels during treatment. Treatment for DKA includes IV insulin and fluid replacement. Alcoholic ketoacidosis is treated with saline solutions and glucose. Treatment for lactic acidosis from decreased tissue perfusion, such as shock, cardiac arrest, rhabdomyolysis due to crush injuries, focuses on correcting the underlying problem and improving tissue perfusion. And rhabdomyolysis is like severe injuries to the muscles, and they'll spill off it looks like muscle breakdown, and you may think that the patient's having a heart attack when it's actually rapid muscle destruction, and you'll see an elevation in your C-reactive protein and may possibly troponin levels, but that is more accurate to the heart, and your cytokines. That's my word I'm looking for. But rhabdomyolysis is a breakdown of muscle. Patients with chronic renal failure and mild or moderate metabolic acidosis may or may not require treatment depending on their pH and bicarbonate level. When metabolic acidosis is due to diarrhea, treatment includes correcting the underlying cause and providing fluid and electrolyte replacement. So our lifespan considerations. Infants are more likely to develop metabolic acidosis from significant losses of bicarbonate and diarrhea. Children with congenital or acquired renal tubular acidosis can lose large amounts of bicarb with or without potassium depletion. Children with metabolic disease such as type 1 diabetes need lifelong insulin administration and good nutrition, education, and support. Metabolic acidosis in the older adult. Many older adults can maintain acid-base balance under normal conditions. Metabolic acidosis in an older adult who presents to the ED may be a consequence of diabetes, renal failure, or ketoacidosis. Accidental overdose of salicylic acid, such as aspirin, may also cause metabolic acidosis, and a lot of our older population are on an aspirin as an antiplatelet. So if you're diabetic and on an aspirin, the probability is it could be high. Older adults experience a high concentration of hydrogen ion in metabolic acidosis, which inversely correlates with serum bicarbonate and PaCO2. Older adults may take more medications because of increased incidence of disease. Like I said, a lot of older adults are on aspirin. They may be taking things like diuretics, antidepressants, anti-seizures, ACE inhibitors. All of these can affect the acid-base balance. A lot of them, again, may be taking acid reflux like Tums and things like that. And so they get their bicarbonate off whack. Outcome depends on the nature of the illness and early diagnosis. So what do we do in the nursing process? To promote health in patients at risk for metabolic acidosis, we want to discuss management of any underlying disease process such as diabetes and renal failure, and we want to help patients prevent complications such as DKA and metabolic acidosis. Because early manifestations of metabolic acidosis such as fatigue, general malaise, diminished appetite, nausea, abdominal pain resemble those of common viral disorders such as the flu, then you just really need to stress the importance to these folks that if you are a renal patient or a diabetic patient and you're feeling this way, and maybe you don't have a fever yet, you might need to go in and be checked because it, might not be the flu, it may be metabolic acidosis. Observation and the patient interview. Ask the patient about current manifestations, including diminished appetite, nausea, vomiting, abdominal discomfort, fatigue, lethargy, and other symptoms. Duration of symptoms and any precipitating factors such as diarrhea and ingestion of a toxin such as aspirin, methanol, ethylene, chronic diseases such as diabetes or renal failure, cirrhosis of the liver, endocrine disorders, and current medications. And you see some of the medicines listed here in the chapter. Physical assessment, we want to look at the mental status. We want to look at their level of consciousness and see if they are coherent or incoherent. Vital sign changes, including respiratory rate and depth, and the apical and peripheral pulses. Are they tachycardic? Skin color, temperature, abdominal contour and distension, bowel sounds, and urine output. Is it diminished? Diagnoses, cardiac output decreased, risk for electrolyte imbalance, deficient fluid volume, excess fluid volume, and risk for falls. Our planning, our goals are describe and demonstrate preventive measures. So we need to make sure that the diabetic patient or the renal patient knows how to prevent this. Be careful with your medicines. Know your signs and symptoms. Have the pH remain within normal range. Have disease process causing the imbalance controlled. Monitor vital signs within the normal range and maintain baseline cardiac rhythm. What are our nursing interventions so metabolic acidosis affects cardiac output by decreasing myocardial contractility, slowing the heart rate, and increasing the rate of dysrhythmias. The accompanying hyperkalemia increases the risk for decreased cardiac output as well. So we want to monitor the vital signs, pulses, hypotension, capillary refill, poor tissue perfusion, I's and O's, dietary restrictions. Monitor the EKG or ECG. Look for hyperkalemia such as peak T waves. Notify the physician of any EKG, ECG changes. Widening of the QRS complex. Dysrhythmias further decrease cardiac output, possibly intensifying the degree of acidosis. Monitor lab values, ABGs, the renal function, electrolytes, the creatinine, the BUN. Frequent monitoring of lab values allows evaluation of effectiveness of treatment. And you have a safety alert. Administer bicarbonate to correct acidosis increases the risk for hypernatremia, hyperosmolality, and fluid volume excess. Sodium bicarb is only administered when pH is less than 7.1. Monitor potential for excess fluid volume. We want to monitor and maintain fluid replacement, monitor the heart and lung sounds, respiratory rate, increasing shortness of breath, adventitious breath sounds, a sign of an S3 in the heartbeat. We want to assess for edema in the back and the sacral area. It's initially dependent in the tissues, and then you may see it around the periorbital, around the eyes. Assess urine output hourly. Note, urine output less than 30 milliliters per hour or a positive fluid balance on 24-hour total intake and output calculations. Heart failure and inadequate renal perfusion may lead to decreased urine output. Obtain daily weights and make sure that it's consistent, same day of time, clothing and scale. Daily weights are an accurate indicator of fluid balance. Administer prescribed diuretics as ordered. Monitor the patient's response. Loop or high-ceiling diuretics such as furosemide or Lasix can lead to further electrolyte imbalances, especially hypokalemia, low potassium. This is a significant risk like that seen during correction of metabolic acidosis. Risk for injury, mental status, and brain function are affected by acidosis, increasing the risk for injury. Nurses working with patients who exhibit altered mental status related to acidosis should monitor their neurological function and usually Some will say every 4 hours. Sometimes you need to do it every hour. If they're in ICU, you're going to do it way more often. You want to look at mental status, level of consciousness, muscle strength. As the pH falls, the resulting decline in mental function leads to confusion, stupor, and a decreasing level of consciousness. Institute safety precautions. Keep the bed in the lowest position. Make sure to call bells in reach. Assign a sitter if needed. These measures help the patient from injury resulting from confusion or disorientation. Keep a clock, calendar, and familiar objects at the bedside. Orient them in the person, place, time, and circumstances. Allow significant others to be with the patient. An unfamiliar environment and altered thought processes can further increase the risk for injury. Significant others provide a sense of security and reduce anxiety. It's always nice to have somebody there, and that helps the nurse out too if a family member can be there to help, watch the patient. Plan for discharge. Consider the cause of acidosis and underlying factors. People who have developed ketoacidosis as a result of diabetes mellitus, starvation, or alcoholism need interventions. They need teaching to prevent future episodes. Diet, medication management, and alcohol dependency are vital teaching areas. When metabolic acidosis is related to renal failure, the patient should be referred for management of the renal failure itself. Patients who have experienced diarrhea or excess ileostomy drainage leading to bicarbonate loss need information about the appropriate diarrhea treatment strategies and need to know when to call their primary care provider. Using appropriate resources to get medical assistance, contacting the primary care provider immediately. Any changes, they need to call the physician, especially if they're dizzy, nausea, vomiting, and fatigue. And then the expected outcome. The patient maintains the pH within normal range. Patient's vital signs return to normal. Patient maintains adequate oxygenation, and patient's able to describe or demonstrate measures to control the disease to prevent future complications. And on page 17, you have a care plan with a little scenario here, and it gives you some labs to assess and the diagnoses and the plan, and then some of the implementation that a nurse would do for a patient in metabolic acidosis. I strongly recommend that you read over the care plan. Thank you.